In this video, we are going to learn some major renal diseases and related topics like applied physiology of the renal system. Learning objectives include describe the diuretics and their mechanism of action, describe the link between disordered renal function and blood pressure, describe renal failure, describe disorders of tubular function, describe basic principles of dialysis. So these are the major learning objectives of this particular video. So before moving on to the complexity of this topic, let's learn some major terms associated with the topic like jargons. Anuria, cessation in the passage of urine due to failure in the function of kidney, although it could be defined as a passage of less than 50 ml of urine per day. So pressure diuresis, increased urine passage when arterial pressure increases. So we will be learning about many topics related to this. So first, diuretics and their mechanisms of action. Diuretics increases the rate of urine volume output, as the name implies. Most diuretics also increases urinary excretion of solutes, especially sodium and chloride. In fact, most diuretics that are usually clinically act by decreasing renal tubular sodium reabsorption, which causes natriuresis like increased sodium output, in turn causing diuresis like increased water output. That is, in most cases, increased water excretion occurs secondarily to inhibition of tubular sodium reabsorption, because sodium remaining in the tubules acts osmotically to decrease water reabsorption. Because renal tubular reabsorption of many solutes such as potassium chloride, magnesium and calcium is also influenced secondarily by sodium reabsorption, many diuretics raise the renal output of these solutes as well. The most common clinical use of diuretics is to reduce extracellular fluid volume, especially in diseases associated with edema and hypertension. So loss of sodium from the body mainly decreases extracellular fluid volume. Therefore, diuretics are most often administered in clinical conditions in which extracellular fluid volume is expanded. Some diuretics can increase urine output more than 20-fold within a few minutes after they are administered. However, the effect of most diuretics on renal output of salt and water substrates subsides within a few days. This is due to the activation of compensatory mechanisms initiated by decreased extracellular fluid volume. For example, a decrease in extracellular fluid volume may reduce arterial pressure and the glomerular filtration rate or GFR, and increase renin secretion and angiotensin II formation. All these responses together eventually override the chronic effects of diuretics in urine output. Thus, in the steady state, urine output becomes equal to intake, but only after reductions in arterial pressure and extracellular fluid volume have occurred, relieving the hypertension or edema that prompted the use of diuretics in the first place. The many diuretics available for clinical use have different mechanisms of action and therefore inhibit tubular reabsorption and at different sites along the renal nephron. The general classes of diuretics, their mechanisms and their tubular sites of action are very important. Then osmotic diuretics decreases water reabsorption by increasing the osmotic pressure of tubular fluid. Injection into the blood serum of substances that are not essentially reabsorbed by the renal tubules, such as urea, mannitol and sucrose, cause a marked increase in the concentration of osmotically active molecules in the tubules. The osmotic pressure of these solutes then reduce water reabsorption, flushing large amounts of tubular fluid into the urine. Then large volumes of urine are also formed in certain diseases associated with excess solutes that fail to be reabsorbed from the tubular fluid. For example, when blood glucose concentration rises to high levels in diabetes mellitus, the increased filtered load of glucose into the tubule exceeds their capacity to reabsorb glucose, like exceeds their transport maximum for glucose. Above a plasma glucose concentration of about 250 mg per dl, little of the extra glucose is reabsorbed by the tubules. Instead, the excess glucose remains in the tubules, acts as an osmotic diuretic and causes rapid loss of fluid into the urine. Therefore, one of the hallmarks of uncontrolled diabetes mellitus is polyuria, frequent urination. which is balanced by a high level of fluid intake, polydipsia due to dehydration, increased extracellular fluid osmolarity, and subsequent activation of the thirst mechanism. Loop diuretics decreases active sodium chloride potassium reabsorption in the thick ascending loop of Henle. Furosemide, ethacryonic acid, and bumetanide are powerful diuretics that decrease active reabsorption in the thick ascending loop of Henle by blocking the 1-sodium 2-chloride 1-potassium co-transporter located in the luminal membrane of the epithelial cells. These loop diuretics are among the most powerful of the clinically used diuretics. By blocking sodium chloride potassium co-transport in the luminal membrane of the loop of Henle, the loop diuretics increase urine output of sodium chloride, potassium, and other electrolytes as well as water for two reasons. They greatly increase the quantities of solutes delivered to the distal parts of the nephrons, and these solutes act as osmotic agents to prevent water reabsorption as well. Then they disrupt the countercurrent multiplier system by decreasing absorption of ions from the loop of Henle into the medullary interstitium, thereby decreasing the osmolarity of the medullary interstitial fluid. Because of this effect, loop diuretics impair the ability of the kidney to either concentrate or dilute the urine. Urinary dilution is impaired because the inhibition of sodium and chloride reabsorption of the loop of Henle ceases more of these ions to be excreted along the increased water excretion. Urinary concentration is impaired because the renal medullary interstitial fluid concentration of these ions and therefore renal medullary osmolarity is reduced. Consequently, reabsorption of fluid from the collecting ducts is increased, so the maximal concentrating ability of the kidneys is also greatly reduced. In addition, increased renal medullary interstitial fluid osmolarity reduces absorption of water from the descending loop of Henle. Because of these multiple effects, 20 to 30% of the glomerular filtrate may be delivered into the urine, causing urine output under acute conditions to be as great as 25 times normal for at least a few minutes. Then, thiazide diuretics inhibit sodium chloride reabsorption in the early distal tubule. The thiazide derivatives such as chlorothiazide act mainly on the early distal tubules to block the sodium chloride counterparts in the luminal membrane of the tubular cells. Under favorable conditions, these agents may cause a maximum of 5 to 10% of the glomerular filtrate to pass into the urine, which is about the same amount of sodium normally reabsorbed by the distal tubule. Then carbonic anhydrase inhibitors block sodium bicarbonate reabsorption in the proximal tubules. Then acetosalamide inhibits the enzyme carbonic anhydrase, which is critical for the reabsorption of bicarbonate in the proximal tubule. Carbonic anhydrase is abundant in the proximal tubule, the primary site of action of carbonic anhydrase inhibitors. Some carbonic anhydrase is also present in other tubular cells such as in the intercalated cells of the collecting tubule. Because hydrogen ions secretion and reabsorption in the proximal tubules are coupled to sodium reabsorption through the sodium hydrogen ion counter transport mechanism in the luminal membrane, decreasing HCO3 reabsorption also reduces sodium reabsorption. The blockage of sodium and HCO3 minus reabsorption into the tubular fluid causes these ions to remain in the tubules and act as an osmotic diuretic. Predictability: a disadvantage of a carbonic anhydrase inhibitor is that they cause some degree of acidosis because of excessive loss of HCO3 minus in the urine. Then mineralocorticoid receptor antagonists decreases sodium reabsorption from the potassium secretion into the secreting tubule. Spirolactone and epilerone are mineralocorticoid receptor antagonistic that compete with aldosterone for receptor binding sites in the collecting tubule epithelial cells and therefore can decrease the reabsorption of sodium and secretion of potassium in the tubular segment. As a consequence, sodium remains in the tubules and act as an osmotic diuretic, causing increased excretion of water as well as sodium. Because these drugs also block the effect of aldosterone to promote sodium secretion in the tubules, they decrease the excretion of potassium. Mineralocorticoid receptor antagonists also cause movement of potassium from the cells to the extracellular fluid. In some instances, this movement causes extracellular fluid potassium concentration to increase concisely. For this reason, spironolactone and other mineralocorticoid receptor antagonists are referred to as potassium sparing diuretics. Many of the other diuretics cause loss of potassium in the urine, in contrast to the mineralocorticoid receptor antagonists, which spare the loss of potassium. Then sodium channel blockers decrease sodium reabsorption in the collective tubules. Amiloride and triamterene also inhibit sodium reabsorption and potassium secretion in the collecting tubule, similar to the effects of spironolactone. However, at the cellular level, these drugs act directly to block the entry of sodium into the sodium channels of the luminal membrane of the collecting tubule epithelial cell. Because of this decreased sodium entry into the epithelial cells, there is also decreased sodium transport across the cell's basolateral membranes, and therefore decreased activity of the sodium-potassium adenosine triphosphate pump. This decreased activity reduces transport of potassium into the cells and ultimately decreases the secretion of potassium into the tubular fluid. For this reason, the sodium channel blockers are also potassium sparing diuretics and decrease the urinary excretion rate of potassium. Then kidney diseases, another major topic, kidney diseases. Diseases of the kidney are among the most important causes of death and disability in many countries throughout the world. Diseases of the kidneys are among the most important causes of death and disability in many countries throughout the world. For example, in 2014, more than 10% of adults in the United States, or more than 26 million people, were estimated to have chronic kidney disease, and many more millions have acute kidney injury or less severe forms of kidney dysfunction. Severe kidney disease can be divided into two main categories, like acute kidney injury, AKI, in which there is an abrupt loss of kidney function within a few days. The term acute renal failure is usually reserved for severe acute kidney injury, where the kidney may abruptly stop working entirely or almost entirely, necessitating renal replacement therapy such as dialysis. And in some instances, patients with AKI or acute kidney injury may eventually recover nearly normal kidney function. And to chronic kidney disease, CKD, in which there is progressive loss of function of more and more nephrons that gradually decrease overall kidney function. Within these two general categories, there are many specific kidney diseases that can affect the kidneys, blood vessels, glomeruli, tubules, renal interstitium, and parts of the urinary tract outside the kidney, including the ureters and bladder. In this chapter, we discuss different specific physiologic abnormalities that occur in a few of more important types of kidney diseases. Next, acute kidney injury or AKI. The causes of AKI can be divided into three main categories. AKI resulting from decreased blood supply to the kidneys. This condition is often referred to as the perennial AKI to reflect an abnormality originating outside the kidneys. For example, perennial AKI can be a consequence of heart failure with reduced cardiac output and low blood pressure, or conditions associated with diminished blood volume and low blood pressure such as severe hemorrhage. Intrarenal AKI resulting from the abnormalities within the kidney itself, including those that affect the blood vessels, glomeruli, or tubules. Postrenal AKI resulting from obstruction of the urinary collecting system somewhere from the calyces to the outflow from the bladder. The most common causes of obstruction of the urinary tract outside the kidney are kidney stones caused by precipitation of calcium, urate, and cysteine. Physiological effects of acute kidney injury. A major physiological effect of AKI is retention in the blood and extracellular fluid of water, waste products of metabolism, and electrolytes. This can lead to water and salt overload, which in turn can lead to edema and hypertension. Excessive retention of potassium, however, is often a more serious threat to patients with AKI because increase in plasma potassium concentration, hyperkalemia, about 8 m equivalent per liter, only twice normal, can be fatal. Oh, that's a very dangerous condition of hyperkalemia happening, like potassium concentration is twice normal. So because the kidneys are also unable to excrete sufficient hydrogen ions, patients with AKI develop metabolic acidosis, which is itself can be lethal or can aggravate the hyperkalemia. Acidosis is also life-threatening. In the most severe cases of AKI, complete anuria occurs. The patient will die in 8 to 14 days unless kidney function is restored or unless an artificial kidney is used to rid the body of the excessive retained water, electrolytes and waste products of the metabolism. Other effects of diminished urine output as well as a treatment with an artificial kidney are discussed later in section. So chronic kidney disease is often associated with irreversible loss of functional nephrons. CKD is usually defined as the presence of kidney damage or decreased kidney function that persists for at least 3 months. CKD is often associated with progressive and irreversible loss of large numbers of functioning nephrons. Serious clinical symptoms usually do not occur until the number of functional nephrons falls to at least 7 to 75% below normal. In fact, relatively normal blood concentrations of most electrolytes and normal body fluid volumes can still be maintained until the number of functioning nephrons decreases below 20 to 25% of the normal. Most important causes of CKD are like AKT can occur because of disorders of the blood vessel, glomeruli, tubules and renal interstitium or maybe reasons like lower urinary tract. Despite the wide variety of diseases that can lead to CKD, the end result is essentially the same, a decrease in the number of functional nephrons. And we have learned earlier that nephrons are, number of nephrons won't increase after the birth. So it's a fixed number. So when we just lose some count of these nephrons, there won't be any regeneration. So these are like neurons, somewhat like neurons. They won't be neurons in the brain, like they won't be, regenerating. They just stop regenerating after the birth. There won't be a fixed number of these nephrons. So when you just face some loss in this number later, life will be compromised as the kidney function will get compromised. Vicious cycle of chronic kidney disease leading to end-stage renal disease. In some cases, an initial insult to the kidney leads to progressive deterioration of kidney function and further loss of nephrons to the point where the person must receive dialysis treatment or undergo transplantation with a functional kidney to survive. This condition is referred to as end-stage renal disease or ESRD. In some cases, the initial insult to kidney can lead to progressive deterioration of kidney function and further loss of nephrons to the point where the person must receive dialysis treatment or undergo transplantation with a functional kidney to survive. This condition is referred to as end-stage renal disease or ESRD. Studies in laboratory animals have shown that surgical removal of large portions of the kidney initially causes adaptive changes in the remaining lymph nodes that lead to increased blood flow, increased GFR and increased urine output in the surviving nephrons. The exact mechanism responsible for these changes are not well understood but involve hypertrophy, growth of the various structures of the surviving nephrons, as well as functional changes that decrease vascular resistance and tubular reabsorption in the surviving nephrons. This adaptive change permits a person to excrete normal amounts of water and solute, even when kidney mass is reduced to 20 to 25% of normal. Over a period of several years, however, these renal adaptive changes may lead to further injury of the remaining nephrons, particularly to the glomeruli of these nephrons. The case of this additional injury is not well understood, but some investigators believe it may be related in part to increased pressure or stretch of the remaining glomeruli, which occurs as a result of functional vasodilation or increased blood pressure. The chronic disease in pressure and stretch of the small arterioles and glomeruli are believed to cause injury and sclerosis of these vessels, like replacement of normal tissues with connective tissue. These sclerotic lesions can eventually obliterate the glomerulus, leading to further reduction in kidney function, further adaptive changes in the remaining nephrons, and a slowly progressing vicious cycle that eventually terminates in ESRD. The most effective method of slowing down this progressive loss of kidney function is to lower arterial pressure and glomerular hydrostatic pressure, especially by using drugs such as angiotensin converting enzyme inhibitors or angiotensin 2 receptor antagonists. Glomerulonephritis in all its various forms are believed to be the most common initial cause of ESRD. In recent years, diabetes mellitus and hypertension have become recognized as leading causes of ESRD, together accounting for more than 70% of all ESRD. Then excessive weight gain or obesity appears to be the most important risk factor for the two main causes of ESRD, diabetes and hypertension. Type 1 diabetes, which is closely linked to obesity, accounts for more than 90% of all cases of diabetes mellitus. Excess weight gain is also a major cause of essential hypertension, accounting for as much as 65 to 75% of the risk for developing hypertension in adults. In addition to causing renal injury through diabetes and hypertension, obesity may have addictive or synergistic effects to worsen renal function in patients with pre-existing kidney disease. In South Asia, infection-related glomerulonephropathies were the main cause of ESRD, but in recent years, owing to the explosion of type 2 diabetes, diabetic nephropathy has emerged as an important cause of ESRD. When we try to look at some causes of chronic renal failure, you can see metabolic disorders, diabetes mellitus, obesity, amyloidosis, and hypertension, renal vascular disorders, atherosclerosis, nephrosclerosis, hypertension, immunologic disorders, glomerulonephritis, polyarteritis nodosa, lupus erythematosus, infections like pyelonephritis, tuberculosis, primary tubular disorders like nephrotoxins, analgesics, heavy metals, urinary tract obstruction like renal calculi, hypertrophy of prostate, urethral constriction, congenital disorders like polycystic disease, congenital absence of kidney tissue like renal hypoplasia. These conditions are some causes of chronic renal failure. When we just take the most common causes of ESRD, you can see about 45% is due to diabetes mellitus, 27% is due to hypertension, 8% is due to glomerulonephritis, and 2% is due to polycystic kidney disease, and other unknown reasons contribute to about 18% of the ESRD patients. End stage renal disease. Then nephrotic syndrome, excretion of protein in the urine because of increased glomerular permeability. Nephrotic syndrome, which is characterized by loss of large quantities of plasma proteins into the urine, develop in many patients with kidney disease. In some instances, this syndrome occurs without evidence of other major abnormalities of kidney function, but more often it is associated with some degree of CKD. The cause of protein loss in the urine is increased permeability of the glomerular membrane. Therefore, any disease that increases the permeability of this membrane can cause their nephrotic syndrome. Such diseases include chronic glomerulonephritis, which affects primarily the glomeruli and often cause greatly increased permeability of the glomerular membrane. Then amyloidosis, which results from deposition of an abnormal proteinoid substance in the walls of the blood vessels and seriously damages the basement membrane of the glomeruli, and minimal change nephrotic syndrome, which are associated with no major abnormality in the glomerular capillary membrane that can be detected with light microscopy. So minimal change nephropathy has been found to be associated with loss of negative charges that are normally present in the glomerular capillary basement membrane. Immunological studies have also shown abnormal immune reactions in some cases, suggesting that the loss of the negative charges may have resulted from antibody attack on the membrane. Loss of normal negative charges in the basement membrane of the glomerular capillaries allows proteins, especially albumin, to pass through the glomerular membrane with ease, because the negative charges in the basement membrane normally repel the negatively charged plasma proteins. So minimal charge nephropathy can occur in adults, but more frequently it occurs in children between the age of 2 and 6 years. Increased permeability of the glomerular capillary membrane occasionally allows as much as 40 gram of plasma protein loss into the urine each day, which is an extreme amount for a young child. Therefore, the child's plasma protein concentration often falls below 2 gram per dl, and the colloid osmotic pressure falls from a normal value of 28 to less than 10 mmHg. As a consequence of this low colloid osmotic pressure in the plasma, large amount of fluid leak from the capillaries all over the body into most of the tissue, causing severe edema. Then effects of renal failure on the body fluids like uremia. The effect of CKD on the body fluid depends on water and fluid intake, and 2. the degree of impairment of renal function. Assuming that a person with complete renal failure continues to ingest the same amount of water and food, the concentration of different substances in the extracellular fluid are approximately those shown in the figure 84.3. like I will be explaining those. NK plus increasing, water increasing, Na plus increasing, H plus phenols, everything will be increasing, and HCO3 minus will be decreasing. So that will eventually lead to kidney shutdown. Okay, so next, important effects including generalized edema resulting from water and salt retention, acidosis resulting from the failure of the kidney to rid the body of normal acidic products, and high concentration of the non-protein nitrogens, NPN, especially urea, creatinine and uric acid, resulting from the failure of the body to excrete the metabolic and end products of proteins, and high concentrations of other substances excreted in the kidney including phenols, sulfates and phosphatase, potassium and guanidine bases. This total condition is called uremia because of the high concentration of urea in the body fluids. Water retention and development of edema in chronic kidney disease. If water intake is restricted immediately after acute kidney injury begins, the total body fluid content may become only slightly increased. If fluid intake is not limited and the patient drinks in response to the normal thirst mechanisms, the body fluids begin to increase immediately and rapidly. With CKD, as long as salt and fluid intake are not excessive, accumulation of fluid may not be severe until kidney function falls to 25% of normal or lower. The reason for this, as discussed previously, is that the surviving nephrons excrete larger amount of salt and water. Even the small fluid retention that does occur along the increased secretion of renin and angiotensin II that usually occurs in the ischemic kidney disease often cause severe hypertension in persons with CKD. Hypertension develops in almost all patients with kidney function that is so reduced that dialysis is required to preserve life. In many of these patients, severe reduction of salt intake or removal of extracellular fluid by dialysis can control the hypertension. The remaining patients continue to have hypertension even after excess sodium has been removed by dialysis. In this group, removal of the ischemic kidneys usually corrects the hypertension as long as fluid retention is prevented by dialysis, because it removes the source of excessive renin secretion and subsequent increased angiotensin II formation. Then hypertension and kidney disease. As discussed earlier in this chapter, hypertension can exacerbate injury to the glomeruli and blood vessels of the kidneys, and is a major cause of ESRD. Abnormalities of kidney function can also cause hypertension. The relation between hypertension and kidney disease can in some instances propagate a vicious cycle, like primary kidney damage leads to an increased blood pressure, which causes further damage to the kidney, further increase in blood pressure, and so forth until ESRD develops. Not all types of kidney disease cause hypertension, because damage to certain portions of the kidney cause uremia without hypertension. Nevertheless, some types of renal damage are particularly prone to cause hypertension. A classification of kidney disease related to hypertension or non-hypertensive effects is provided in the following section. So, renal lesions that reduce the ability of the kidneys to excrete sodium and water promote hypertension. So, renal lesions that reduce the ability of the kidneys to excrete sodium and water promote hypertension. Renal lesions that decrease the ability of the kidneys to excrete sodium and water almost invariably cause hypertension. Therefore, lesions that either decrease GFR or increase tubular reabsorption usually lead to hypertension of varying degrees. Some specific types of renal abnormalities that can cause hypertension are as follows, like increased renal vascular resistance, which reduces renal blood flow and GFR. An example is hypertension caused by renal artery stenosis. Then decreased glomerular capillary filtration coefficient, which reduces GFR. An example is chronic glomerulonephritis, which causes inflammation and thickening of the glomerular capillary membranes, thereby reducing the glomerular capillary filtration coefficient. Then excessive tubular sodium reabsorption. An example is hypertension caused by excessive aldosterone secretion, which increases sodium reabsorption mainly in the cortical collecting tubule. Then once hypertension has developed, renal excretion of sodium and water returns to normal, because the high arterial pressure causes pressure natriuresis and pressure diuresis. So intake and output of sodium and water becomes balanced once again. Even when there are large increase in renal vascular resistance or decrease in the glomerular capillary coefficient, GFR may still return to nearly normal levels after the arterial blood pressure rises. Likewise, when tubular reabsorption is increased, as occurs with excessive aldosterone secretion, the urinary excretion rate is initially reduced but then returns to normal as arterial pressure rises. Thus, after hypertension develops, there may be no obvious sign of impaired excretion of sodium and water other than the hypertension. And normal excretion of sodium and water at an elevated arterial pressure means that pressure natriuresis and pressure diuresis have been reset to a higher arterial pressure. Then specific tubular disorders. We point out that several mechanisms are responsible for transporting different individual substances across the tubular epithelial membranes, and each cellular enzyme and each carrier protein is formed in response to a respective gene in the nucleus. If any required gene happens to be absent or abnormal, the tubules may be deficient in one of the appropriate carrier protein or one of the enzymes needed for such transport in the renal tubular epithelial cell. In other instances, too much of the enzyme or carrier protein is produced. Thus, many hereditary tubular disorders occur because of abnormal transport of individual substances or groups of substances through the tubular membrane. In addition, damage to the tubular epithelial membrane by toxins or ischemia can cause important renal tubular disorders. Then, renal glycosuria, failure of the kidneys to reabsorb glucose. In renal glycosuria, the blood glucose concentration may be normal, but the transport mechanism for tubular reabsorption of glucose is greatly limited or absent. Consequently, despite a normal blood glucose level, large amounts of glucose pass into the urine each day. Because diabetes mellitus is also associated with the presence of glucose in the urine, renal glycosuria, which is a relatively benign condition, must be ruled out before making the diagnostic procedure of diabetes mellitus. Renal tubular acidosis, failure of the tubules to secrete hydrogen ions. In renal tubule acidosis, the renal tubules are unable to secrete adequate amounts of hydrogen ions. As a result, large amount of sodium bicarbonate are continuously lost in the urine. This loss causes a continuous state of metabolic acidosis, and this type of renal abnormality can be caused by the hereditary disorders, or it can occur as a result of widespread injury to the renal tubule. Then nephrogenic diabetes insipidus, failure of the kidneys to respond to antidiuretic hormone. Occasionally, the renal tubules do not respond to antidiuretic hormone, causing large quantities of dilute urine to be excreted. As long as the person is supplied with plenty of water, this condition seldom causes severe difficulty. However, when adequate quantities of water are not available, the person rapidly becomes dehydrated. Then Fanconi syndrome, a generalized reabsorptive defect of the renal tubule. Fanconi syndrome is usually associated with increased urinary excretion of virtually all amino acids, glucose and phosphate. In severe cases, other manifestations are also observed, like the failure to absorb sodium bicarbonate, which result in metabolic acidosis, increased excretion of potassium and sometimes calcium, and nephrogenic diabetes insipidus. There are multiple causes of Fanconi syndrome, which results from a generalized inability of the renal tubular cells to transport various substances. Some of these causes include hereditary defects in cell transport mechanisms, toxins or drugs that injure the renal tubular epithelial cells, and injury to the renal tubular cells as a result of ischemia. The proximal tubular cells are especially affected in Fanconi syndrome caused by tubular injury, because these cells reabsorb and secrete many of the drugs and toxins that can cause damage. Next, treatment of renal failure by transplantation by dialysis with an artificial kidney. Severe loss of kidney function, either acute or chronic, is a threat to life and requires removal of toxic waste products and restoration of body fluid volume and composition toward normal. This can be accomplished by kidney transplantation or the dialysis with an artificial kidney. Approximately 600,000 patients in the United States are currently receiving some of the ESRD therapy. Successful transplantation of a single donor kidney to a patient with ESRD can restore kidney function to a level that is sufficient to maintain essential normal homeostasis of body fluids and electrolytes. Approximately 18,000 kidney transplants are performed each year in the United States. Patients who receive kidney transplants typically live longer and have fewer health problems than do those who are maintained with dialysis. Maintenance of immunosuppressive therapy is required for almost all patients to help prevent acute rejection and loss of transplanted kidney. The side effects of drugs that suppress the immune system include increased risk of infections and for some cancers, although the amount of immunosuppressive therapy can usually be reduced over time to greatly reduce these risks. Approximately 400,000 people in the United States who have irreversible renal failure or total kidney removal are being maintained chronically by dialysis with artificial kidneys. Dialysis is also used in certain types of AKI to tide the patient over until the kidney resume their function. If the loss of kidney function are irreversible, it is necessary to perform dialysis chronically to maintain life. Because dialysis cannot contain completely normal blood fluid composition and cannot replace all the multiple functions performed by the kidney, the healthy patient maintained with the use of artificial kidney usually remain significantly impaired. Then basic principles of a dialysis. The basic principle of the artificial kidney is to pass blood through minute blood channels bounded by a thin membrane. On the other side of the membrane is a dialyzing fluid into which unwanted substances in the blood pass by diffusion. Components of one type of artificial kidney in which blood flows continuously between two thin membranes of cellophane. Outside the membrane is a dialyzing fluid. The cellophane is porous enough to pass the constituents of the plasma except the plasma proteins to diffuse in both directions, from plasma into the dialyzing fluid or from the dialyzing fluid back into the plasma. If the concentration of a substance is greater than the plasma than the dialyzing fluid, there will be a net transfer of substances from the plasma into the dialyzing fluid. The rate of movement of about solute across the dialyzing membrane depends on the concentration of gradient of the solute between the two solutions, the permeability of the membrane to the solute, the surface area of the membrane, and the length of the time that the blood and fluid retain in contact with the membrane. So, when we just look at the structure, we can see there are fresh dialyzing solution, structure which contain fresh dialyzing solution, then constant temperature bath, used dialyzing solution, and dialysate out, dialysate in, dialyzer will be there, blood in, and the bubble trap will be there. Semi-permeable membrane is shown here with waste products are there, water flowing, blood flowing, dialysate, and you can see the structure and principles of dialysis with an artificial kidney. Thus, the maximum rate of solute transfer occurs initially when the concentration gradient is greater when the dialysis is begun, and slows down as the concentration gradient is dissipated. In a flowing system, as in the case with hemodialysis, in which blood and dialysate fluid flow through the artificial kidney, the dissipation of the concentration gradient can be reduced and the diffusion of solute across the membrane may be optimized by increasing the flow rate of blood and dialysing fluid or both. In normal operation of the artificial kidney, blood flows continuously or intermittently back into the vein. The total amount of blood in the artificial kidney at any one time is usually less than 500 ml. The rate of flow may be several hundred milliliters per minute, and the total diffusion surface area is between 0.6 and 2.5 meter square. To prevent coagulation of the blood in the artificial kidney, a small amount of heparin is infused into the blood as it enters the artificial kidney. In addition to the infusion of solutes, mass transfer of solutes and water can be produced by applying a hydrostatic pressure to force the fluid and solutes across the membranes of the dialyzer. Such filtration is called bulk flow or hemofiltration. Dialysing fluid. Constituents in a typical dialysing fluid include like Na plus K plus electrolytes and non-electrolytes like glucose, urea and creatinine. Note that the concentrations of ions and other substances in dialysing fluid are not the same as those in the normal plasma or in uremic plasma. Instead, they are adjusted to levels that are needed to cause appropriate movement of water and solutes through the membrane during dialysis. Note that there is no phosphate, urea, urate, sulfate or creatinine in the dialysing fluid. However, the substances are present in high concentrations in uremic fluid. Therefore, when a uremic patient undergoes dialysis, these substances are lost in large quantities into the dialysing fluid. The effectiveness of artificial kidney can be expressed in terms of amount of plasma that is cleared at different substances each minute, and is the primary means for expressing the functional effectiveness of the kidney themselves to rid body of unwanted substances. Most artificial kidneys can clear urea from the plasma at a rate of 100 to 225 ml per minute, which shows that at least for the excretion of urea, the artificial kidney can function only twice as rapidly as two normal kidneys together. Those urea clearance is only 70 ml per minute. Yet the artificial kidney is used only for 4 to 6 hours per day, 3 times a week. Therefore, the overall plasma clearance is still considerably limited when the artificial kidney replaces normal kidneys. Also, it is important to keep in mind that the artificial kidney cannot replace some of the other functions of the kidney, such as secretion of erythropoietin, which is necessary for red blood cell production. So, thank you for listening.